it will fill with the fat. Again, I'll just emphasize on this. So whenever there is an intra-articular pathology, this any collection or the hematoma will pop out from here, and fat will displaced anteriorly or the posteriorly. So again, this will form the recess. We have posteriorly olecranon recess. The radial side, we have radial recess and the coronoid recess. Again, these recesses are very important. Any which way we'll see these recesses on ultrasound also. And the last one is the annular recess. So in a nutshell, we have this anterior and posterior muscle. In between the joint, we have this blue articular cartilage. In between the articular cartilage, you have the synovium, which secrete the synovial fluid. Then we have something called as the lateral synovial fringe. This lateral synovial fringe is like an meniscus, which will, dip into this joint. Then outside we have the capsule, and outermost structures we have apopolaterals from the medial and the lateral side. Then we have this fat pad present anteriorly and posteriorly. So let's back to the anatomy. What we are using, we are using the protocol which are given by the European Society of the Musculoskeletal Radiology. To get a good musculoskeletal images, we need to have a good ultrasound machine, and we should use high frequency probe. So for anatomy purpose, we should have a segmental approach for elbow. So we have anterior elbow, then we have lateral elbow, we have medial and the posterior elbow. So in the anterior elbow, what are the things which we need to find out? So these are the things. We have the brachialis muscle, the bicep brachii muscle and the tendon, the brachioradialis muscle, the supinator, pronator teres. We have brachial artery and the vein. This brachial artery is very important landmark in the anterior elbow. Then we have median and the radial nerves. So why I am tracing, why I'm going so much of detail of these muscles, because each of the muscle is very important, and we'll find out every muscle on the ultrasound. So first we have this brachialis muscle, which is a deep muscle. It originates from the mid shaft of the humerus and insert over the coronoid process of the ulna, and it is one of the main flexor of the elbow, whether your arm is in arm is in pronation or the supination. Then we have the bicep brachii muscle. All of us know it has a two heads. We have the long head and the short head. The long head originates from the supraglenoid tubercle and the short head from the coracoid process. As these two heads runs distally, they form the bipinnate muscle, the muscle belly, and distally they have the biceps tendon, which insert on the radial tuberosity. So one of the important point I would like to mention here is something called as a lactatus fibrosus or the bicep aponeurosis. So this fleshy thing, lactatus fibrosus, is nothing but it's an facial expansion which wraps around the tendon, and this crosses the forearm over the medial neurovascular bundle and insert to the medial deep fascia. So importance of this lactatus fibrosis is, as you can see, it crosses the it originates from the biceps tendon, so it will protect the A bicep tendon. B, it will cross, so it will protect your neurovascular structures. And what happens whenever there is a distal biceps tendon tear? So if the lactatus fibrosis is intact, it will prevent the retraction of this biceps tendon proximally, right? Then again, this biceps tendon, if you look at it, is 7 centimeter long with no synovial membrane, but it is surrounded by a paratenon. If you divide the biceps tendon into the zone 1, 2, and 3, the zone 2 is one of the hypovascular zone, and it is covered by the lactatus fibrosis, what we have discussed. The zone 1 is basically supplied by the brachial artery from here, and zone 1, as I told you, is a hypovascular zone, more tears occur here, and the zone 3 is supplied by the recurrent radial artery and the posterior interosseous arteries. Then we have the brachioradialis muscle. It originates from the lateral supracondylar ridge of the humerus, and it attaches proximal to the stylar process. And its actions is to flex the forearm, to stabilize the elbow, and pronation and supination. Then another muscle in the anterior elbow, we have the supinator muscle. So this is one of the funny muscle. Why? Because it has a multiple bony origins. It arises from the lateral epicondyle here, then along the lateral collateral ligament, then along from this annular ligament, and a posterolateral surface of the ulna, that is the superior crest, and it inserts over the proximal lateral surface of the radius, and one of the important action is to supinate the forearm. Then we have this pronator teres muscle. So this is one of the important muscle because our one of the median nerve will pass through this. So it has the humeral head and the ulnar head, and these both the heads unite and attaches to the proximal lateral aspect of the radius, and the action is to pronate and the flex the forearm. So we'll wind up the things what we have learned so far. Yes, we have this deep muscle is the brachialis. Above the brachialis, we have this biceps tendon with the bicipital aponeurosis. Then laterally, we have brachioradialis. Just adjacent to the brachioradialis, medially, we have this supinator muscle with its two heads. Then medially, we have the pronator teres muscle. And then our important landmark is the brachial artery in the midline. Just adjacent to the brachial artery in medial part, we have the median nerve, and medial most structure is the vein. And the laterally, we have the radial artery. So I think so far, so good, everything. So this is very important structure. You just copy the structure and paste in your mind, because when we put a probe in the short axis here at the anterior elbow, we'll get this sort of image. So we have this medial epicondyle, the lateral epicondyle, and this sort of quadrangular shaped muscle is the brachialis muscle. If you go slightly medially, we have the pronator teres muscle. In between the brachialis and the pronator, you have our median nerve. If you go laterally, we have the brachioradialis muscle. So in between the brachialis and brachioradialis, we have the radial nerve, and the lateral most structure is the supinator. Posteriorly, we have the anconeus, and the posteromedially the ulnar nerve. And this anterior most structure is the distal biceps tendon. Right? Yes. So we'll start with an sonoanatomy. So what all the position is very important. So patient should be lie in supine with the arm resting at the side, arm at the side and wrist in a supinated position. So what all structure and how to evaluate? Yes, what we'll do, we'll have a transverse sweep from 5 centimeter proximal to the elbow joint to 5 centimeter distal to the elbow joint. And during that, what we'll evaluate? We'll evaluate biceps, the brachialis, the brachial artery, and the median nerve. So we'll evaluate distal biceps tendon, which is very much prone for anisotropy. So we'll follow the tendon in the long axis also up to the radial tuberosity. Then we'll evaluate the anterior joint recesses for any synovial hypertrophy, synovitis, and small effusions. Then we'll evaluate the radial and the posterior interosseous nerve along their courses in the short and the long axis. Right? In a short axis, so there are important things what we need to remember. We should use a lot of jelly. Mind my words, musculoskeletal ultrasound, use your jelly. Don't do conjusi over here, right? So you should hold the probe like you are holding a pen. The marker should be facing towards you or the machine. So what we always ask that you should support the your little finger should rest on the patient body, so that you can get the good stability while getting probe up and down and toggling here and there. So if we look at the short axis, so we'll put the short axis in the probe here in the anterior cubital fossa. So what we'll get, this hyperechoic structure is the capitulum on the lateral side and the trochlea on the medial side. Then what we have, this hypoechoic thing, is the articular cartilage. Above the hypoechoic, we have the hyperechoic rim, that is the capsule, and this quadrangular shaped muscle, what I have shown in many of the anatomical images, is the brachialis muscle. Then one of the important landmark is the brachial artery. Then this hypoechoic tendon, which has an prone for an anisotropy, is the brachialis, so bicep brachii tendon. Then just medial to the brachial artery, we have median nerve, and on the lateral side, we have the radial nerve. So again, medially we have pronator teres and laterally the brachioradialis. So we'll again say this anatomy because it is very important to learn this anatomy on the anterior aspect of the elbow. So median nerve will lies between the brachialis and pronator teres, and the radial nerve will lies between the brachioradialis and the brachialis muscle. So I'll just run this clip for you, right? So this is the bicep. As we go down, it will form the biceps tendon. As I go down, here the bicep tendons are formed as I go down. At the midline structure, we'll just move our probe medially. So I'm just moving my probe medially to look for this structure. So this is the brachialis, this is the pronator teres muscle, and this is the median nerve. If I go laterally, I'll just stop here. So this is the brachialis muscle. This is the brachioradialis. In between, we have this radial nerve, which is already divided here. So I'll again run this video for you. So this is the bicep muscle. The biceps tendon is forming here. At the center, we'll just go medially. The pronator teres, the median nerve, the brachioradialis, and the radial nerve here. Right. So in the long axis, what we'll do, we'll put our probe in a long axis in such a way that we are covering the distal end of the humerus and the radial. So we are placing the probe here. Then what we'll do, we'll just go medially to evaluate the structures. So in the lateral side, we have the radius and yes. So this hypoechoic area is the articular cartilage. This hyperechoic thing is the capsule, and above that you have the brachialis muscle. On the ulnar side, we have the trochlea and the coronary process of the ulna, and this is the brachialis muscle. So always remember to look for this fat pad. So minimal fluid is acceptable, not an issue for us. But whenever there is any pathology, so I have shown you the diagram. The synovium will lie down on this bone, and any intra-articular pathology will lift up this fat and will get the positive fat pad sign on sonography also. So similar on the radial side. So this is the fat what we have discussed. Right. So to trace the biceps tendon, I have already told you it is very much prone for anisotropy. Right. So we'll place our probe in a short axis at around 5 centimeter proximal to the joint line. Then we'll go down along the course of the biceps. I'll just show you the video. So this is the bicep muscle, this is the biceps tendon as I am going down. So see, this is very much prone for anisotropy. So to evaluate the distal end of the biceps, what we need to do, we need to do an coronal oblique view. So in the coronal oblique view, so this will go along the course of the biceps tendon. So this is the distal biceps tendon. So this small muscle is the supinator, this is the radial tuberosity. So this is the long head of the biceps tendon, which is attached proximally, and you have the short head, which is attached slightly distally. And it's very important to use this window of a brachial artery to look for this biceps tendon. That will really help you. So for that, we need to have an proper coronal oblique view. Then one of the favorite maneuver is the cobra maneuver. What here patient is lie down supine. We ask patient to do flexion and we'll just ask to do an cobra position and we'll evaluate dynamically for in supination and the pronation. So here so here, this is the biceps tendon. As we are doing pronation and the supination, the biceps tendon is going in and out. So while doing this, you have noticed that it is very much prone for an friction here. So for that, we have this bicipito-radial bursa. Usually it is not seen whenever there is a effusion or any abnormality. We can clearly see this bicipito-radial bursa. And this cobra position is very important to give an injection along the biceps tendon. So we'll just approach from this end and we'll put our needle here. Yeah. So I have already discussed this thing is the Lasata's fibrosis. It is very important structure. So I'll just stop here. I'll just go down. So this is the bicep muscle. Here is the biceps tendons are getting formed. So the two heads are getting formed. I'll just go down, down. As you see here, there is an this structure is coming from this. So you just watch out for this structure. It is going laterally. It is going laterally, and it will merge into the medial fascias. So here the again the importance of this Lasata's fibrosis, it supports the dual action of the bicep. It holds the distal biceps tendon and the neurovascular structure. And one of the important thing is it prevents the retraction of the ruptured tendon. So this is the Lasata's fibrosis or the bicipital aponeurosis. We have the brachial artery, distal biceps tendon. So it will, covers the biceps tendon and the neurovascular structure. We have the median nerve here. So so far we have learned the muscles and the tendons. Now it's time for to look for the median nerves. So you have the two heads of the pronator teres in between. This median nerve will run. This median nerve will come from this anteromedial aspect of the elbow, which will pass through the humeral and the ulnar heads of the pronator teres. Then it will pass through the flexor digitorum superficialis and the flexor digitorum profundus. As it goes distally, it will come superficially and eventually it will enters into the carpal tunnel. So we'll trace the median now. So we have learned, yeah. So we have brachialis muscle in the midline, the medial we have pronator teres, and here is the median now. In the video, I'll just go back. Yeah. So here the midline muscle is the brachialis. We'll trace this median now. This is the main important anterior elbow landmark is the brachial artery, just medial to the brachial artery. We have the median now. As I go down, so this is the pronator teres. This is the brachialis muscle. I'll just so concentrate on this honeycomb like structure. I'll just go down distally, distally. So yeah, so here, so this is the what I was telling, the ulnar head of the pronator teres, and this is the pronator tunnel. So this nerve will pass between this tunnel, and this small hypoechoic thing is the adjacent artery. So your deep head will differentiate or the differentiate between this artery and the nerve, and they make it separate from as they courses down. Again, this is things, right? So to look for the radial nerve, we have learned the anatomy. The central bulky deep muscle is the brachialis. Above we have the biceps muscle. Laterally, this orange color is the brachioradialis muscle. Then we have the supinator in between. So this radial nerve will come into the antecubital fossa. Laterally, it will divide into the superficial and the deep branch. This deep branch is the posterior intraosseous nerve, which will pass through this supinator muscle, and it has more chances to get compressed during this course. So this is the axial section of the elbow. What we have learning so far is laterally we have brachioradialis, centrally we have brachialis, and this is the radial nerve. So this is the somewhat long axis image of the posterior intraosseous nerve. So this posterior intraosseous nerve, so this hypoechoic area, it is going down here in between the two heads of the supinator, and this hyperechoic is the area is called as the arcade of Rose. Whenever there is a hypertrophy of this, it will indent on these adjacent nerve and leads to the symptoms of the posterior intraosseous nerve. So I'll just show in this video. So this nerve is already divided. We'll just go down. So this hypoechoic thing is the radial recurrent artery. Sometimes what happens, the artery may compress over the posterior intraosseous nerve and leads to its symptoms. So as I go down, so it will turn here, and it will lie between. So it's a supinator tunnel. So this is the supinator tunnel. So this is the superficial and the deep head of the supinator muscle. Okay, yeah. So next, so far we have learned the anterior elbow things. Then what all the checklist for the lateral elbow? We have the common extensor tendon, we have the radiocapitellar joint, and the lateral collateral ligament complex. So if we look at the lateral elbow anatomy, we have the lateral epicondyle, and the four important tendons are attached to these lateral epicondyles. So this bulky footprint is of an extensor carpi radialis longus, just inferior or the caudal to this. We have our extensor tendons. We have extensor carpi radialis brevis. Then we have extensor digitorum communis, then extensor digiti minimi, and extensor carpi ulnaris. So, how to scan this common extensor tendon? So, patient is in supine position, elbow is in flex at around 90 degree, and forearm at rest and prone. So, we'll put our probe sagittally over the lateral joint line, and what we'll get is this image. So, here is a lateral epicondyle. Yes. So, this is the lateral epicondyle, the radius, and we have the joint space here. And this is the what we call as common extensor tendon, which attached to the lateral epicondyle. But we have learned, many tendons are attached to this lateral epicondyle. So we are just saying it's a common tendon which attach. So are we really able to see the different tendons? Yes, it is difficult to see, but yes, we can see the tendons separately. So for that, what we'll ask, because during what position I showed you that time, your extensor tendons are, relaxed position. So we need to make it taut so that we can differentiate. So what we'll ask patient to flex the elbow and just, push this hand so that we can have an extension of this extensor tendons. So we'll again same, we'll put the probe along the lateral epicondyle. So what we'll get is this image. So this hyperechoid is the extensor carpi radialis brevis. This muscle belly of extensor digitorum communis. Then we have extensor digiti minimi and extensor digitorum longus combined unit will attach and as a common extensor tendon, and we have supinator, and below it we have radial collateral ligament and annular ligament complex, right? So yes, this is the extensor carpi radialis brevis, the extensor digitorum communis, extensor digiti minimi, and the extensor digitorum longus. Here is the supinator and the radial collateral ligament annular ligament complex. Then if you look at the lateral collateral ligament complex, they are not easy to find out, but yes, we'll try to make it clear. So first we have the radial collateral ligament. So this originates from the anterolateral epicondyle and distally blends with an annular ligament. So this is the annular ligament which encircles the radial neck attached around the radial notch of the ulna. Yeah. Then we have the lateral ulnar-collateral ligament that is called as the LUCL. It is arises from the lateral epicondyle to the supinator crest of the ulna here, and it is one of the important stabilizer for posterolateral rotator instability. Yes, if you look at this thing, if you go slightly down from the above thing, we'll see this radial collateral ligament, which will blends along this annular ligament, and below it we have the lateral ulnar collateral ligament. Then another structure in the lateral compartment is the radiocapitular joint. So again, this is the head of the radius, this is the capitulum, and this hyperechoic thing is called as the lateral synovial fringe. Usually this is normally seen hyperechoic, but sometimes it may get inflamed and patient will come with symptoms of locking of the elbow joint. So evaluation of this lateral synovial fringe is also important. So we can check here, we'll ask to prone and supinated to move the radial head, and we can check the stability of underlying ligaments here. Then we'll just turn our approach to the medial side of the elbow. We need to evaluate these two things, common flexor tendons and the medial collateral ligament. So if we look at the common flexor tendons, we have basically these four tendons. The outermost is the flexor carpi ulnaris. Inside is the flexor digitorum superficialis, then palmaris longus, and the innermost is the flexor carpi radialis. All of this tendon, it forms a common tendon which inserts on the medial epicondyle of the humerus. So there are ligaments on the medial side. We have medial collateral ligament. It has three bundles. You have an anterior bundle which runs from the anteroinferior aspect of the medial epicondyle to the sublime tubercle of the ulna. It is a major stabilizer in valgus instability during the elbow extension. Then you have the posterior bundle of medial ulnar collateral ligament, which will runs from the anteroinferior aspect of the medial epicondyle to the medial olecranon, and it stabilizes the it's the main stabilizer during the valgus instability during the flexion. Then we have the transverse bundle of the medial ulnar collateral ligament. It is so basically this is medial from the coronary process, and it will go toward the ulnar medial olecranon between these two bundles. So for evaluation of the medial elbow, we'll ask patient to lie down supine with arm in abduction, with forearm in supination and elbow at 90-degree flexion. We'll place our probe longitudinally over the medial epicondyle, and what we'll get is this image. So over this hyperechoic tendon of a common flexor tendon, we have this medial epicondyle, the ulna, and this is the ulnohumeral joint. So in this image, this is the muscle belly, and the inferior to it we have an anterior band of the medial collateral ligament, what we have learned just. So there are important techniques while doing the scan. So what I have done, so from my proximal end of the probe should be touching over the medial epicondyle. I'll just toggle my probe so that it will in the range of your thumb, or the probe will edge facing towards the radial aspect. So that time I will get this image. What I have shown you here is the common extensor tendon, so common flexor tendon. Then if I if I turn this probe medially towards the ulnar side or little finger, what will get this beautiful diagram of this ligament is, yes, we have this image of the medial ulnar collateral ligament here. So it's very important that one end of the probe should be over the medial epicondyle, and you just need to toggle your probe from the thinner aspect to the hypothenor aspect to evaluate the extensor common flexor origin and the medial collateral ligament respectively. So if we look at the posterior elbow, so we have this checklist. We have the triceps tendon here. We have the posterior humeral recess. We have the olecranon and the subolecranon bursa. Then we need to find out the cubital tunnel, and the ulnar nerve. So in the posterior elbow anatomy, we have the tricep muscle. As the name suggests, it has three heads. We have the long head, the lateral head. Both 2L, that is long, and lateral head will conjoin will form and conjoin tendon will attach to the olecranon process of the ulna. So this long head will arise from the infraglenoid tubercle of the scapula, and the lateral head will arise from the radial arise superior to the radial groove, and inferior to the radial groove we have the origin of the medial head. So basically the medial head is it is one of the important for the extension of the forearm. The long head helps to stabilize the shoulder joint and prevents its dislocation, and it extend and adduct the glenohumeral joint. So for the tricep muscle in the posterior approach, so we'll ask patient to flex the elbow at 90 degree with the palm resting on the table. So what we'll get this fibrillary structure of the triceps, and we'll examine the long and the short head of the triceps insertion to the olecranon in the both the axes. To look for the posterior humeral recess, again the same position, elbow is flexed at 90 degree with the palm resting on the table. So we'll put our probe in the long axis to evaluate this fat containing structure. This is the olecranon fossa in the long axis, and then the short axis, we'll just put our probe in the short axis. We'll go slightly cranially, and what we'll get is the short axis view of the olecranon fossa. So this olecranon fossa is containing the fat and the synovium. So any pathology in the joint will lift up this fat and giving the fat pad sign on the sonography means also. So examination of these triceps and the posterior fat recesses are very crucial. So sometimes what happens, this is one of the frequent site for your loose bodies to be fall down here, your chondral, your articular cartilage, loose bodies, and calcific foci will be getting there. Next, it is very important that you should use lot of jelly here. Will just touch the probe to the surface of this jelly. We are not compressing this jelly. We are using this as a window for us. It is called as the floating technique. So for this, again, the position will be same. Elbow is flexed at 90 degree with palm resting on the table. For to look at the olecranon bursa or the subolecranon bursa, usually in the normal individual, it is difficult to see because unless and until there is a pathology, it will not fill up. So this is an the expected position of this olecranon bursa or the subolecranon bursa. Next structure in the posterior elbow, what we have the ulnar nerve. So it has a bit complicated anatomy. In the posteromedial elbow, as the ulnar nerve comes, it will pass through the arcade of Struther. So what is the arcade of Struther? Is the musculoapneurotic canal along the medial intramuscular septum. It go down caudally below the medial epicondyle here, and just adjacent to it we have the tricep. In the posterior to the medial epicondyle, it is running into the cubital tunnel, and the roof of the cubital tunnel is formed by the Osborn ligament or the Osborn retinaculum. So again, this is one of the site for compression. As it goes down, and it will pierce the flexor carpi ulnaris to enters into the forearm. So, what is the position to examine this cubital tunnel and the ulnar nerve? So again, patient arm is abducted with a 90-degree elbow flexion. So these are the bony landmarks. What we have discussed, mind my words, the bony landmarks are very, very important. Yeah. So we have this medial epicondyle and the olecranon prosa. We'll just put our probe to join this line. So we'll just join this line. We'll exactly put our probe here, and what we'll get is this thing. So this hypoechoic structure is the median, the ulnar nerve, which is just adjacent to the medial epicondyle. Then this structure which form the base of this cubital tunnel. Here is the posterior component of the medial collateral ligament, right? So so we have evaluated the cubital tunnel. So it is mandatory to do a dynamic study to look for the integrity of the ulnar nerve, because what happens sometimes the ulnar nerve is sublux and it will come over the medial epicondyle. So in this position, what we'll do, we'll ask the patient to arm should be abducted with 90-degree flexion at the elbow, and dynamic study, that is flexion and extension of the elbow, what we have performing here. So so far I have shown you all the normal things, and this is the last I think image that I'm showing you the pathological slide, right? So here, so this bony landmark is the medial epicondyle. This hypoechoic, thickened, swollen is the ulnar nerve. So as we go ahead, so this examination done in the extension. So I have asked patient to do a flexion. So the patient is doing flexion. So look at this hypoechoic thing. It is getting up along with someone is coming from behind, which is pushing the ulnar nerve to go medially. See, this is the medial nerve and it is subluxing over here, and along with that hypertrophied tricep muscle is also subluxing here. So this is nothing but snapping tricep syndrome. So we'll just run this video for you again. So this is swollen thickened ulnar nerve along with this tricep which is pushing this thing and it is getting down, right? I think we have covered most of the thing from the anterior elbow, the lateral, the medial, and the posterior elbow. So, what I think is in a nutshell, this I think this slide is very important because there are many things while you have to doing whenever you are doing a musculoskeletal ultrasound, there are very important things you should keep in mind. So anatomical knowledge is must. You should know the bony landmarks. They are very, very important because whenever you lost while doing your scan, you just go back to your bony landmark, then scan again. That will really help you. Follow the protocol. That is very important. So what happens, while following the protocols, you should ask the patient history. You should very important, because the thing is we will follow the protocol, yes, but we can do a localized examination also by we'll ask patient where is the exact pain, and we can go ahead with that examination. It is mandatory to use high frequency probes and look for anisotropy. So there are two tendons, the long head of the biceps, the biceps, the distal biceps tendon, and the what we have the triceps. These both are very much prone for anisotropy. For the distal biceps tendon, you shoot in a coronal oblique plane along the biceps and use the brachial artery as a window for it. And the to look for the triceps, you should use as much as of jelly. Then in a musculoskeletal ultrasound, probe movement should be very slow. So what happens, we have habit of doing fast movement of the probe. It should be a very gentle and in a proper manner. Always remember to any of the structure, you should examine the structure in a two orthogonal blur. It is mandatory. You cannot complete your examination by saying, yes, I have seen this structure in axial plane. No, you should see, because the tendons and the ligaments, we need to see in all the planes. When in doubts, so this is the very important advantage. When in doubts, compare with the opposite side. Go to opposite side, and you will compare with the things, and it will help you. Use the split screen. What we use, if you want to examine any structure, use a long and short axis in two split screens. Dynamic evaluation is very important in the musculoskeletal ultrasound. That is the main advantages over the other cross-sectional imaging, is the dynamic evaluation. You always remember, any whatever USG of an MSK you are doing, do a dynamic evaluation. And this is what I think is very important, is take a proper history. So I'll just tell you the example. Suppose patient is having tingling numbness along the finger, and you are suspecting an a carpal tunnel syndrome. You just ask patient whether the patient is having a sort of hypothyroidism, or it's a female who having hypothyroidism. That will help you to get a good diagnosis. So history taking is very important. During my practice, I always speak with the patient, take as much as history, because what I think, what we have learned is the history taking is very important. But what I think, patient usually came with the diagnosis. We just need to write down on a paper. So usually patient comes with the diagnosis. We just find it out and write it down on a paper. If possible, do simple clinical test. So if patient is having a radial sided wrist pain, and you are suspecting an dequarantinosynovitis, just do an Finkelton test. That will help. That will build up your confidence in the musculoskeletal ultrasound in your initial phase. Use Doppler whenever required, because as I have shown you, the synovium dip down around the bones. In a pathologies like synovitis, synovial hypertrophy, the loose bodies, and the tendinosis, you will require Doppler. So use the Doppler things. So I think I have covered everything, and this nutshell is very important. Whenever you are doing any sort of MSQH, you should remember this point. Thank you so much.
Thank you so much, Dr. Sanket. There are a couple of questions. Can you see the Q&A tab?
Just a second.
It will be exactly near the participants, the screen share screen tab.
Um, yeah, I think it's in the chat, right?
Not the chat. That is a separate Q&A tab. More, can you click on more and see whether
Yeah,
you
yeah,
are able?
yeah. So someone is asking to show the cobra maneuver. Yes, you are supposed to do bicep from the dorsal aspect. Basically, if you look at the cobra maneuver, the second question is bicep, supposed to look for the biceps tendon along the dorsal aspect. Why? Because it is, I told you, it is important during the injection purpose, and we check the integrity of the biceps tendon. So I'll just show that and some. So I'll just share my screen. So someone want anterior approach to be shown again. I'll explain. Okay, share. Is my screen is visible? Yeah,
No, the initial screen which in a nutshell is visible right now.
yeah, yeah. I will go ahead. Mm, mm, just a second. I'm not able to go at the top of the slide.
Close and open again. Close the share screen and stop and share again.
Stop share.
Try try to stop and reshare again.
Yeah, it's so. I'll just answer the first question. I will show the cobra maneuver once again. Yep. So here, so again, patient is lying down supine with the arm, with the elbow at the flexion, and what we'll do, we'll put our probe at the radial tuberosity from the posteriorly, because the thing is, your biceps tendon will come from the anteriorly, it go down and attach to the posterior aspect of the radial tuberosity. For that matter, what we need to, we'll ask patient to do this cobra position, and for that. Uh, will ask to do an pronation and the supination. So during that movement, what happens? Your biceps tendon will pop out. So basically, this cobra maneuver is very important while doing an your injections and to look for this bicipitoradial bursa. So two important things. You just go and practice this. It's very simple. Nothing rocket science here. Just look for the radial tuberosity, the ulna and the radial tuberosity. You see this hyperechoic horizontal line, and you'll just ask patient to rotate his forearm, and you'll clearly see this something is going in and out. So that is the biceps tendon. Next question is yeah, I'll just show the anterior elbow anatomy, right? So for that matter, what we need to do again, so basic thing, so we just put our probe into the anterior elbow at the anterior cubital recess. Over there, what we see is this structure. In this structure, we just need to toggle your probe up and down, so we'll get this good image of this hyperechoic, hypoechoic, and hyperechoic structure. So this hyperechoic area is the articular. This is the bony cortex. This hypoechoic thing is the articular cartilage. Above we have the capsule, right? This sort of quadrangular shaped structure muscle is the brachialis. Above that, we have very important landmark is the brachial artery, right? So I think up till now we have clear. So anteriorly, put your probe in the anterior middle part of your cubital fossa. Then you get this good image. The quadrangular muscle is the brachialis. Above we have brachial artery, right? adjacent to the brachial. So what I always remember is the brachial artery, because that will help you a lot. Whenever you are just toggling probe up and down, your movement should be very slow, because what happens, to get this hyperechoic line, to get these articular surfaces, it is difficult. But as you do the practice more and more, you will get good image. So this brachial artery, adjacent or the medial to the brachial artery, we have median nerve, and laterally we have the radial artery, medially pronator teres and brachioradialis. So this, I think, video will help you a lot. So I'll just start this video. So deep down muscle is the brachialis. Above that, because we have started, up 5 centimeter up. We have starting. We are going from this to down. So this chunky muscle is the bicep muscle, and this hyperechoic is the biceps tendon, which is getting formed. As I go down, so you see the muscle will getting smaller and the tendon is getting formed. So you can clearly see these two ends, this and this end. As I go down, right? So these are the two separate tendons. What I can see, the long head will, go in a spiral thing and will attach proximally. Yes, I will just go distally at this region. So we'll just toggle our probe medially. So it's a gentle movement. I'll just sweep my probe medially. So medially we have pronator teres and the brachialis. In between you have the median nerve. Then I'll just come midline. Then I am just going laterally. So this is the brachioradialis muscle, and these are the hypoechoic dots are the radial now, and this central is the brachialis muscle, right? Okay, so I think it's an and the next is this approach. In the that was in a short axis. This is the long axis. You just put your. That's why I am. I have start my presentation with the surface anatomy. You just put your probe here and just go medially. You will get these good images. Okay. Then so this is very important to trace the biceps tendon, because what happens, patient may came with the distal biceps tendon rupture, so we need to find out how much it is retracted from where it is torn. So we'll start our examination 5 centimeter proximal from the joint line. We'll go right. Yeah. So this central muscle is the bicep muscle. We are forming the biceps tendon as we go down. So that will, prone for anisotropy, and to get rid of this anisotropy, we'll put our probe in the coronal oblique. So I have started axially from this. I turn my probe in a long axis and slightly oblique coronal view. I'll get this beautiful image. And you should always look through the brachial artery. It is one of the good window while looking for this distal attachment of the biceps tendon over the radial tuberosity. Right. So I think this is the anterior approach. Then some of the questions are, yeah. Hmm. Acha, please share the anterior elbow checklist. I will share. Acha, ulnar snap again. Okay. The report template, what we are using is an European guideline, that is European Society of Musculoskeletal Radiology. You just Google it and you will get entire PDF of this normal protocol, and you can make your own protocol. There is nothing big in the protocols. Yeah, it was basically someone is asking any help with nerve compression syndromes, imaging features. You depend upon the rate of positive findings. Again, this is an basic anatomy. We'll have another talk on the pathology also. Someone is asking what is the average time of doing an elbow UAG. So there is nothing an average time. So some initially you may take some longer time because you need to adapt with this normal anatomical structure. If you are well versed with the normal anatomical structure, then you can find out the pathological thing. So initially it will take time, but as you are getting pro in the things, you will see the structures. Okay. Okay, I'll show the ulnar snap again. Anterior elbow checklist. Yes, I will. Yes, it is possible to exclude injury or tendinosis of the common extensor tendon origin from any associated adjoining injury of the lateral and collateral ligament. So basically, what I think it's a challenging structure. Lateral epicondyle is one of the challenging structure to get these images because the small ligaments are very difficult. But yes, we can differentiate because I have shown you the another approach to make the lateral common lateral extensor compartment, lateral common extensor compartment, how on the compression of or the how other maneuvers will make it taut, and we can simply find it out the structures. Please show the position of elbow for medial and lateral compartment. Okay, so I'll answer these two questions. Okay, so my screen is visible, right?
Yes.
Yeah. So someone is asking what is the checklist. So this is the checklist for the anterior elbow. You can take a pic for this anterior elbow checklist. Then we have, yeah. So this is the lateral elbow checklist, the common extensor tendon, the radiocapitular joint, and the lateral collateral ligament complex. Then we have this, yeah, it's a medial elbow checklist, the common flexor tendon and the medial collateral ligament. And the posterior elbow is this triceps, the posterior humeral recesses, olecranon bursa, and cubital tunnel and the ulnar nerve. I'll just show this video. So basically, we'll so surface landmark are very important. So you should pick part with your anatomist. So this is the medial epicondyle, right? This bony projection, hyperechoic thing with posterior shadowing is the medial epicondyle. Just adjacent to the medial epicondyle, it's the hypoechoic. There are no fascicular patterns seen in this. So obviously, it is hypoechoic and thickened nerve as I go. So this is in the extension what I have examined. So I have asked to do flexion. So during flexion, what happens? This ulnar nerve will sublux over the medial epicondyle. So what happens? You may have isolated snapping of the ulnar nerve, or you may have an association with the uh, triceps muscle also. So what happens? Sometimes there is an hypertrophy of the tricep muscle. You see, so someone is pushing. So what happens during the flexion? There is a small space in the posterior medial compartment. So during flexion, it is getting shorter. So this tricep is pushing your ulnar nerve over the medial epicondyle, and you may hear the two snaps of as the ulnar nerve and the triceps. So basically, this is an snapping tricep syndrome with the ulnar nerve subluxation. And someone, I think I have answered all the things, right? Hello, am I audible?
Yes, yes, Dr. Sanket.
I think I have shown everything and answered the things. So thank you so much
So,
for,
we
yeah.
will wind up for now. If, uh, If you want to answer any of the question, you may take it, or we can wind up for
Accepting
now.
the questions. I think all questions. Please show. The last question was the please show the position of the. Someone wants position. Na? Yeah, that was the last question. This is anterior compartment. So this is the position for the lateral compartment. So elbow is in a flex position, forearm at the rest and pointed, and we are keeping our probe sagittally over the lateral joint line, and we'll get this image. For better image means to differentiate the structures, we'll use this maneuver. So try go back and do this sort of maneuvers. We'll ask patient to, extend the hand so that your extensor tendon will get taut and we can see separately. And one more is the position of medial. Yeah. So this is the position of the medial elbow. So arm is abducted, forearm is in supine position, and flexion at the elbow, the 90-degree flexion at the elbow, and you will get this image. And for this, to look for the common flexor origin, so basically you keep the proximal end of your probe over the medial epicondyle, and you just sweep this probe from the thenar and the hypothenar region. So I remember like T for thumb, T for thenar eminence or the thenar muscle. So you just make sure your probe is facing toward the thumb, and in another, so you will get this good image of the common flexor tendons. I have just turned the probe medially toward the ulna or the little finger, and you will get this image of this common, the medial collateral ligament very beautifully. And we can do a valgus stress over here so that you can have a good image of MCL along with you can see this joint, how much it is opening. That is a different thing. Okay.
Okay, thank you so much, Dr. Sanket. You may
Thank
see
you.
how much your talk has been appreciated and liked. Really happy, everyone is happy with your talk, and we will like to see you back again in this platform with